Okay. Hi guys, good evening. Welcome back to another webinar by Beating Hearts. I'm very proud to say that today's webinar is slightly different from the rest
Tengah
because we are.
activity banyak gila. Yang minggu ni banyak pasal pneumonia. Asma.
That's why I have to mute everybody. Sorry. Try to mute yourself when you come in, please. If not, there will be a lot of distraction. Okay, so I'm very proud to say this is the first webinar that we are doing in collaboration with somebody else, and we also giving these CPD points. So I have with me here Dr. Shawn. Dr. Shawn is a consultant surgeon from Beacon Hospital, and he will teach us a little bit on techniques to minor surgeries that we can do as GPs. So Shawn, take it off. I will go and find the CPD thing while you do this. Okay, go ahead.
Right. Okay. Thank you, Betty. Today topics will be techniques to minor surgery for GPs. It will be a very short and nice things. Hopefully you'll enjoy and think few time before you all do any procedure in the clinics. Sorry.
Of the thing,
Sorry,
Right.
I hope you all can unmute. Okay, go ahead.
Right. So I would say all the surgeons when we training time, we carry ourselves a small cemetery. When times to times, I'm going to pray in the cemetery. Likewise, I think all the doctors should have a ruler in their heart. They should know what they can do, what they should do, and where is their limits, when to stop. That's why during the clinic sessions also, when you see a patient, you should know your limit and you should know your abilities. After that, before I starting, I just share a bit about myself, but in the locum life. I think you all are very familiar with the words of locum. No, I'm not sure nowadays still have locum. No, supposed to be have a lot. I'm starting my locum time on 2002 when I was still a house officer. That time the locum rate is 20 ringgit per hour.
You do locum during house officership. Is it even
Yeah.
legal?
Locum is never legal until don't know like 2006 or 2005 like that.
I
That time we
see.
already paid 20 ringgit per hour sitting in the clinic. Then that time I was house officer. My MO told me, hey, this Saturday you got time for locum or not? Cover me for whole Saturday. The clinic gives you a free dinner. Yes, I'm interested. Then I joined in. Since then, roll and roll, more and more clinic you call, hey, you got time to locum, got time locum. Until a point of time when I starting MO stamps, the clinic, that time a lot of 24 hours clinic, they need somebody to sleep in. 10 p.m. to 6 a.m. they pay a flat rate of 180 ringgit. So from every night we are going to sleep in the different clinics to just to earn the 180 ringgit over the night. It's not per hour, it's all night, 10 p.m. to 6 a.m. 180 ringgit. That time, that time our on-call claim per day in government hospital was 25 ringgit per day. On call 8 a.m. to 8 a.m. is 25 ringgit. When I on call of 13 or 14 calls a month, I get 200 plus ringgit. I was so happy, wow, extra 200 plus ringgit. Then you think back, locum time 180 ringgit per night. So I rather every night sleep in different clinics. Then later I found out some locum in emergency department, various hospitals, all the private hospitals start hiring locum. So a bit better rate of 35 ringgit per hour. Only then until after 2005, government legalized locum, and a lot of even general hospital, they want locum and they pay very high rate, 80 ringgit per hour. That time onwards, all the locum life mainly is in GH in the government hospital already. Even until my master time, I still doing locum. Every Saturday, Sunday, went to my friend's clinic in Sri Kembangan, 2 p.m. to 10 p.m. Every Saturday, Sunday, no miss. Then on and off, you do some locum in UMMC that time. So that's how the locum life. And I found out what thing we can do in clinic and what thing we shouldn't be doing in the clinics. And now it's all concluded. I've left locum since I'm joining as a specialist. So today is a good time. I conclude anything that we can do or anything that we cannot do. So before starting, I divide it into 3 categories. One is a common procedure that everybody should be able to do. And some procedure that we can do in clinic, but we need some training. And the last part is procedure that we can do, but it need more specialized training and more specialized equipment, not commonly done. You think you can do it, to think twice whether you should do or shouldn't do. Then there are these 3. So first thing first, I'm talking about the common procedures first. When the Japanese say Japanese can do attitude is when one can do, I can do also. If one cannot do, I must do it. There's Japanese or there's some common attitude everybody should have lah. But Malaysians boleh attitude usually. If one can do, let him do. If one cannot do, what can I do? Or you during facing the problem, you're thinking a common procedure I want to apply the Singaporean don't do. If everybody do, as I might die must do. You think which one you want to go, then you choose. So first procedure I would say is incision and drainage lah. Commonly known IND. Patients come in with a pus coming out like that. I think a lot of people that well trained or even not well trained, you should know how to do just to drain some pus out lah. But this is a dirty procedure or contaminated procedure. I have to bring back my locum times again when there was like 10 years ago. When we clean the wound, we drape the wound with newspaper. Now I told people that when my locum time, I did an IND with newspaper around the patients. Then a lot of people amazed and scared. Why newspaper? What the thing? What you're doing? I said, I'm not the clinic doctor. Is the owner of the clinic. Tell me, please use newspaper. So I don't know what newspaper, but anyway, this patient with the IND, if you want to use newspaper, is all right because dirty procedure anyway. Just the advice I give you, you need to give local anesthesia, and use a size 11 blade. Size 11 blade is the one I show there with the pointed tips. The one is you poke inside and cut. As you see the picture, I make a lot of cross. There's an area you should give the local anesthetist and this local anesthesia agent. Usually I use lignocaine or xylocaine, whatever fast acting agent that you want. If you want, you can mix one fast acting with one long acting also can. After you give the surrounding area, then use the size 11 blade, poke in and cut all the way out, drain all the pus, clean it out with normal saline, then you can pack with gauze, and that's it. Afterwards, you can ask patient every day come back to do dressing, change the gauze until the wound heal by itself. This incision.
How long will it usually take?
Is as big as the wound, as big as the pus cavity. But some people, you think you don't take so big pus cavity, at least have to ease your dressing. You don't make too small, like 1 inch or 2 inches. Sometimes it's very difficult for you to do dressing later. Every time you do dressing, patient will feel pain because most of the dressing time is without any sedation anesthesia region. So patient will feel pain. The bigger the wound you make, actually the patient will feel less painful. Don't get the thing terbalik. Make small incision, patient less painful. You big incision, dressing time, patient less painful. And when the wound heal, you heal from surrounding towards the center. You won't heal at the center first. So the wound eventually will shrinking,
Shawn,
becomes
Shawn,
smaller.
can I stop you for a while? Can you hear me?
Yes.
Somebody says, Aziza says, she can't hear anything. Anyone have a problem?
Sorry?
I can hear Shawn quite well. Anyone have problem? Maybe she has a problem with her connection. I'm not sure. Aziza, I see that you have just signed in again. Interrupted a bit. Yeah, interrupted just now for a while, but the sound in itself is quite clear, I would say. Okay. K1 say can hear very well. Okay. Aziza say can hear now. Okay, can go on.
All
Sorry,
right, okay.
Yeah.
It's all right, sorry. I just open up these things first. So this is incision and drainage lah. I'll advise big incision, easier
Big
dressing,
incision.
less painful.
I think the reason why people go for small incision these days, I see a lot of videos that go viral on pimple popping. And when there is a small incision, I realize the effect of this pimple popping is exaggerated because the pressure you put comes out from a very small hole. So it becomes like a volcano. Whereas if let's say you make a big incision, the pus then drains out not like in a projectile way, so they don't have that effect. So at the same time, if you actually do this drainage, I think you should take a video also, because every time it goes viral.
No, you do big incision, the
Ah.
video effect not good because it's
Yes,
don't
the
have
video
something
effect not good.
shooting out. It's
Yes.
something like I call it punch it out. People are like wow, 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 like that.
Yeah.
That's why people make small incision. If you want a video, you make a small incision, you make it punch it out, then you extend the incision and do a proper dressing. Then
Okay,
you
that's a good idea.
get famous for cleaning like, wow, these doctors see the incision so good. You make yourself own viral.
These days we have to think about every aspect of medicine, which includes social media also. Okay, go on.
Yeah, the next thing is aspiration of abscess. Even though the first principle tell us every abscess we should be drained, but I have to tell you, not all abscess have to make a big incision and drain it. Yeah, I know I contradict to what I said just now, but this is specialized, is particular to special body part, mainly to the face, to the neck region, and to the breast. Especially in the breast and the face, when you have the abscess, we more keen towards an aspirations. Put the needle in with a 16 gauge 16 gauge needle or 16 gauge granula, and poke into the abscess cavity and aspirate it. Ultrasound will help you how long you should aspirate and what is the direction of aspirations. And aspiration sometimes needs multiple procedure. You better tell the patient earlier, see, look, you have an abscess. This area I'm not encouraged. I do not encourage you to use an incision because of the wound. You make the area ugly. But I'm going to use aspiration method. But the problem is you have to come back every other day to let me have a look. Might be need repeated aspiration 2 to 3 times, sometimes need 4 to 5 times for a big abscess. This is basically had to emphasize face or breast. You show very good result. Nowadays, big breast abscess, especially all the lactating lady, nowadays we have already away from incision already. We use aspirations.
I see. Serena did ask, is it better to aspirate some before cutting? In any case, for example, if you're going to make an incision, would you aspirate first before you cut?
I was thinking you should if you think want to cut, you cut directly, don't aspirate. Because after aspirate, the cavity lost in pressure. After you aspirate, you might cut too deep. When your size
I
11
see.
blade poke in, you might poke too deep. When there's abscess there, when you poke and the abscess come out, you know, yes, this is the depth that I should go. Then you start extending your incision towards the edge of the abscess. It's better to cut directly instead of aspiration. You think you want to aspirate, you don't cut anymore, just aspirate only.
So it's either or, never together,
Yes,
right?
yes, yes. 1 second.
Okay, Serena asked, especially for gluteal abscess. How about gluteal abscess?
For gluteal abscess, I'll say you must incise, don't aspirate. Aspirate won't help you. Gluteal abscess is a very difficult abscess. Just now I did tell you abscess, we do an incision one line, but for gluteal abscess, I will say incision a cross line. Make a crisscross there, like a T or like a cross, like a whatever thing cross. The reason is in buttocks region, the skin heal very fast, but the cavity heal very slow. If you didn't do a crisscross incision, the skin will heal before the cavity heal, then the abscess is going to accumulate again. When the abscess accumulate again, you're going to do another IND again. That's why in gluteal, surely IND, don't think of aspirations. All right.
Okay.
So I come to my next thing is IV line lah, IV line insertion or IV injections. Sometimes patient come to your clinic, you are unavoidable to set a granula and give some fluid. I'm not sure nowadays still people giving any fluid replacement, any crystalloid, any colloid, anything for patients or not. I'm not very sure.
Anyone giving, is it a routine practice that you all set lines and give fluid replacement for patients either because, so Serena said yes. Yeah, basically because it's hypovolemia, think that is hypovolemic and you want to give some fluid replacement, or you want to give a first dose of antibiotic, which is also yeah, I would think
Okay.
that the setting line is quite a basic thing, right? For
Yeah,
GP
everybody should
practice.
know how to do because our houseman time we set line in and out. Until
Yes, that's
now,
right.
when you acquire the technique by now, you shouldn't lose the technique lah. But during my locum time, what I always find during IV is giving some IV first dose of antibiotics to the patients, give some symptomatic injection like IV. That time we, instead of using any PPI, we are using H2 antagonist or this
Oh,
even now I cannot remember ranitidine. We give an IV
ranitidine.
ranitidine. Nowadays nobody use ranitidine. Directly give pantoprazole, omeprazole, Nexium, all these things. But maybe some first line some IV Maxolon, IV metoclopramide also is quite commonly give patients. And sometimes, actually quite a numbers of times, during my practice, the patients you brought in some vial of vitamin C, collagen. Doctor, can
Oh,
you inject for me or not? This IV collagen, IV vitamin C, some IV don't know what things is very good. So I like, this thing. Then sometimes you think you should inject or you shouldn't inject. It's up to you. I have no comment about that. But I personally did help patient injected all these things before, but I did tell patient, I don't know what you bring, as long as it's not narcotic, it's not poison, it's not toxic, it's not morphine type of drugs. It labeled
how do you
some,
know it's not narcotic?
it's
How
labeled,
do you know?
there's
Did they
something,
check? They come and give it to you.
the vial you label, is a printed
I
label.
see.
That's
Okay.
why when starting, I say everybody must have a ruler in the heart, whether what should you do and what you shouldn't do. Sometimes people misuse this thing and you're not sure whether you should do or you shouldn't do. Then you ask your heart, you should do or you shouldn't do. These is very tricky things, you know. I face a lot
Yes.
of time, IV vitamin C, IV collagen, all these things we also have. All right,
Fine.
this IV line, this is all
I've
IV line.
never done locum before ever in my life, so I really
That's why I
don't
can,
know. Yeah.
when Dr. Betty approached me talking about GP procedure, like, I have so many years of locum I can share now actually.
Yeah. Interesting. Okay.
So the next is dressing lah. Commonly we use all the traditional thing, povidone, saline, Euso, dermacin, whatever. Traditional that dressing should change once to twice a day. So patient should come back to you every day or usually it's every day lah, come back to change dressing, then you adjust the patient, then you discharge the patient the next day, come again. No? Nowadays, we have more modern dressing. Modern dressing, all the hydrocolloid dressing, all the foam dressing, all the arginate dressing. This modern dressing, the good thing is, I think I have another slides there. Modern dressing, the good thing is no need daily change. So patient can escape the pain of the dressing. You can tell the patient every 2 days or every 3 days. Sometimes it's a clean wound. Some of the clean wound, I even tell the patient to come every week to change once a week only. unlike the traditional dressing, you have to change every day. But of course, the price is so much different. Traditional dressing is so much cheaper compared to the modern dressing. If you want to do a modern dressing, when the wound is clean and granulating, you use a hydrocolloid type of dressing. If the wound is dirty, suppurative, a lot of pus come out, you use arginate or foam dressing. I didn't mention any brand here lah. I have particular brand I always use, but this is not a commercial thing. They didn't pay me, so I didn't mention the brand. If you want to know, you online and check hydrocolloid dressing. There are few dressing example you come out. And you type alginate dressing, few example will come out. Foam dressing, few example you come out. So you choose which one you want. But the rule of thumb is the wound is clean and granulating, use a hydrocolloid. When the dirty pus suppuration, you use arginate or foam dressing.
Can the patient do dressing at home?
Can, if the patients know how to do it or there's a relative trained enough, they can do it. In fact, I have a lot of patients, their relative is good enough to do dressing at home. So they just come to see me once a week or once every 2 weeks to assess how clean or how dirty the wound is. Sometimes even some not, the patient is ambulation problem, they difficult to bring the patient in. I'll tell the relative, you take some snapshot from time to time, you send the snapshot to me. I'll tell you whether you can stay at home and continue your dressing, or you should do some slough debridement things. This is what I want to talk now. Or you have to bring back for me to do. There's up to the patient choice, the relative, how the wound condition and how competent the relative feel.
In
So
actual
the next
fact,
thing I'm talking,
the use of telemedicine for this type of cases is also possible because the patient has seen you once. So for telemedicine, you can only for follow-up. So you can actually check the patient's wound on telemedicine, which I think is a great idea for GPs. We
yes,
need to think of,
that's good. So you
yeah,
keep contact with the patient will quite close to you. But
yes, true.
the drawback is because I give patient my numbers, then the patient every other day you text me, doctor, this okay or not? Doctor, this okay or not?
Yeah,
Then I'll
yeah.
tell them, don't call me, you text me, I'll try to reply to you. Then every other day you get a lot of pictures until a point of time you forgot who to who already. Why this one dressing, which one, which
Yes,
to
so
which
it
you
is
might
better
confuse,
to
but
use
somehow you get used to
telemedicine,
it.
even if it's free, and you can also charge through telemedicine. And there's a lot of platform that you can actually use. Um, I like to, I'm not, I mean, I don't do it big time, but I've signed up with me. Yeah. So now we go on to removal of debris and oh,
There's a title, debridement. Somehow the title didn't come out.
okay.
This debridement is if the wound is dirty after IND or a sloughy wound, you might thinking of debridement. Debridement, there are a few options you use. You can use a forceps. You can just use cotton and gauze and with some saline to rub the thing out, or you can even use some saline irrigation. And this thing I want to show you is a curage. Sometimes we use a curage to dig out all the dirty, sloughy tissue. And actually a lot of sloughy tissue, the tissue already dead. So patient wouldn't have pain sensation over the slough. You no need to give any local anesthesia, no need to give any pain control before you do the desloughing. But to certain area, if the pain is there, then you can give some local injection of lignocaine, the short-acting analgesia region, or you can use some lignocaine spray to that area. So the pain, you numb the area before you do this laughing. Or debridement wound now only come out. So these are two examples of wound of the patients come to my clinics. You can see one wound is quite some slough covering it. Despite the normal dressing, tell the patient to come back, we do some desloughing. So in clinics, I'll just use the curate things to curate all the sloughy tissue before I apply a dressing. After you curate the sloughy tissue out, the next thing you apply the alginate or foam dressing, and you can tell the patient come back every other day. So every other day, the patients will come back to change the dressing. If there's a somebody, a caretaker who can take care of the patient and do a quite well dressing at home. You can just use normal saline dressing. With the after you disrupt the area, you put saline soap gauze into the wound, and you tell the patient to change the wound. The caretaker to change the wound every day. Then you'll be easier for the patients. This is the wound that come to me with like this slough. After the debridement, you see all the slough come out all around the area and the wound start bleeding. You have to see the bleeding to know that the wound is healthy. If you didn't see the bleeding, that means the wound is not healthy. You still need to deslough more. This one I use a curage to curage all the slough out until it's bleed. Then I pack with saline gauze. Like just now I said, the slough tissue have that there's no sensation. So in this case, I didn't give any analgesia, any painkiller, anything to numb the area. Just curate the dirt tissue out, then pack with saline. The patient afterwards is quite you'll be okay lah.
So this one you have to do it every day?
No, desloughing is when the wound is dirty. So from times to times, like I told you just now, patients have usually the patient is dressing at home. The relative do the dressing or patient do their own dressing. And sometimes to time they send picture to me. And the wound reach this state, I tell you, don't do at home. Come back to hospital, I'll do for you. Then every other day patient will come back, then you clean the wound, then let the patient go back. So this laughing debridement thing only for dirty wound and for unnecessary only. Or else you can just use a dressing. I'm currently use all this modern dressing to clean the wound and pack the wound, then let the patients go back. Okay, next thing is CBD lah, continuous bladder drainage. I suppose everybody should know how to do on and off. Patients come to you, doctor, I cannot pee. Then you feel a palpable urinary bladder and you insert the CBD. Usually what you face is, one second, sorry. Hey, Shasma, I call you back. Bye. Another thing is, this usually patient cannot pass urine is though male patient with BPH, benign prostatic hyperplasia. After they retain the urine for too long, then the urine cannot pass out, then they'll look, usually they go to emergency lah, on and off they'll come to clinic. When they come to clinic, you know, this is the time that you shove the CBD in and release the problem. The problem you might face in a male patient with huge prostate, you cannot insert the CBD. And a lot of people try to give, going for a smaller size and smaller size, even smaller size. You go to smaller size, the CBD won't go in at all. The advice is go the bigger size. The bigger, the better. And sometimes, yes, and the technique sometimes might be challenging because our urethra, men's urethra is an S shape. You have to negotiate through the S shape. There are certain technique to manipulate the penis for the CBD to go in. The suggestion is big size. I usually use size 20, 22, 24, big size. The bigger size, the better for you to go in. And sometimes rubber CBD cannot go in. So you use a silicone CBD, make it easier to go in because silicone CBD more stiff. Put more jelly inside, more this lignocaine gel around the CBD, and you even can inject some lignocaine gel like the picture show. The man inject the thing into the penis. The one was lignocaine gel. Squeeze the lignocaine gel in a syringe, shove inside the meatus and hold it for about 1-2 minutes for it to numb the area. Then put the big CBD in. Urologist will tell you only 2 conditions a normal CBD cannot be inserted, or you cannot never go in the normal CBD never been able to be inserted. The 2 conditions are, first, urethra stricture. Second, prostatic cancer. Only these 2 conditions the CBD cannot go in. Others conditions the CBD should be able to go in. Just the technique only. So if you really feel a CBD, you should doctor will say, please go to emergency of the hospital. The hospital doctor should know what to do. But some doctor whether anyone of you here inserted an SPC before or not, suprapubic catheter, to from the some two finger breadth above the symphysis pubis, fill a urinary bladder and put some lignocaine injection. Then poke. There was a specific set to put in suprapubic catheter. Poke a suprapubic catheter inside into the urinary bladder. Previously, we do it in like blind technique. We fill the urinary bladder, then we make the incision, we poke the SPC inside. But nowadays, with the availability of ultrasound, I'll advise people to use ultrasound at least to guide where is your insertions. Because throughout my life, I seen once a very senior MO, graduated as a junior specialist time. He inserted his confidently, this is palpable urinary bladder, put in the SPC, then feces come out.
My
That
God.
means he already perforated the bowel. Then there's a tragedy lah, sure habis. So better with ultrasound, at least confirm first. Don't be like, oh, very, very sure, it's a urinary bladder, nothing get wrong. Then you poke in and the feces come out, it's different story. So I'm not sure now anybody inserted any suprapubic catheter. You think you cannot do it, don't force yourself to do it. Send the patient to emergency department. Let the doctors there do it.
I never seen it done before.
Different training. We all hear in and out every other day we have some SPC to be inserted. So next thing is wound suturing. Yes, anything?
No, nothing. I'm just
All right.
okay, go on.
Right. Next thing, wound suturing. Patients sometimes come into you, some cut wound, some minor accident. They don't want to go to emergency department. They say, doctor, can you suture my wound? That's the time like, I have a friend GP. He did like 100 suture for patients of multiple small cut during a road vehicle accident. Windscreens break and somehow cut him, don't know how many pieces of things. So he stitched up about 100 stitches. I think a lot of people you like to do this type of TDNS, wound suturing, and maybe some people you feel like I don't want to do this, very messy. It's very personal. I would say if you find any wound, do a simple interrupted suture. Sometimes you might need some mattress suture, but I'm not encouraging you to do any continuous suture. Don't be lazy to do continuous suture. Always the effect not good. So it's possible just do some simple interrupted suture. Now we're going to touch something about suture. We have a lot of sutures material that we can use. Monofilament, braided, absorbable, non-absorbable, natural versus synthetic. The size of 2O, 3O, 4O, until 5O, 6O also have. Needle size, there are various needle size and various needle shape for particular purpose. If I think this one is confusing and a lot of people don't know what to choose and how to choose. Actually, this is a photo I put up here for you. If you don't know, look at this thing. I should erase the name of the company lah.
Don't
Use a
worry lah.
non-absorbable monofilament 2O or 3O suture. Okay, non-absorbable monofilament 2 or 3O, simple interrupted suture or vertical mattress suture. This type of suture, these last two are the suture method, and the first three are the material of suture that you should choose. Then usually it's usually covered mainly 99% of all type of wounds. This is about the suture method. Simple interrupted suture is just to cross over, then you tie a knot all go to the same side of the patient. Then vertical mattress suture is you make something like coming out and going in again. A little bit complex, but this one is better holding and better
Hey, Shawn, you're
healing.
breaking up.
But
You're breaking up.
For the mattress suture,
Shawn?
usually I advise for those wounds have some tissue loss. If there's no tissue loss, no skin loss, you can approximate easily. Then you use
Okay, Shawn is breaking up. Sorry, Shawn, can you hear me, Shawn? Because you are breaking up. Okay, so I do a little bit of suturing since I have to cover Shawn for a while. And most times I do suturing when we do pacemakers. So we have to cover up layer by layer. Basically, we cover up layer by layer to reduce the risk of infection spreading downwards. And also we do layer by layer so that we actually suture it well and reduce the risk of also bleeding. So we do that. So any questions? Please think of questions and put it up first. I've lost Shawn completely. And then hopefully when Shawn comes back, we can take some questions that you have asked. Oh, this is the first time that's happening. Anyone want to say anything at all? Help us out here with anyone with experience with sutures or minor surgeries in the GP setup. Because I did work as a GP nurse when I was waiting for my SPM result. And I really have to say that because IND gave a lot of satisfaction. Okay, Shawn is back. Shawn?
Hello.
Yeah, Shawn. We
Yes.
lost you for a while.
Yes.
So
yes.
Serena say use nylon for face 4O and or 5O.
Yes, for face, there's particular area. Face need the 4050 nylon better. You can use 5060 even better. And use small stitches called interrupted suture. Simple interrupted suture. Right, we reach here. So when there's tissue loss, you use vertical mattress suture. When there's no tissue loss, the skin can approximate nicely, then use a simple interrupted suture. Yes, face is different. Face is because very precious place. Do a 50 or 60 suture. The problem of 50 and 60 suture is you need a special needle holder. The normal needle holder cannot do. So you have a special forceps type of needle holder, the one you helps you a lot. Then, of course, after you suture, after some time, you ask the patient to come back to suture removal. When the stitch removal, usually is advised 1 week to 2 weeks time lah. For body trunk, for the trunk, I remove in a week time. For extremity, the hand and the legs, remove in 2 weeks time. But for face, usually remove within 5 days. 3 days to 5 days. Sometimes some small precious area, 3 days I remove already. But usually it's 5 days. That's how the suture removal.
Why longer in
The
the
healing process a bit slow in the extremities. Trunk, the healing process will be faster. Right, okay. These are the common procedure that usually people do lah.
in GP practice, right?
In GP, yes. So the next thing talk about is procedure can be done with some training. This some training, these words is very famous among surgeons or when junior surgeon, junior MO, MO in surgical department, houseman stroke MO in surgical department, or nail bed injury. I use a 3O or 4O suture, just nail bed, sometimes if the nail been involved, no need any suture, just dressing, you heal up by itself. Only in cut wound, only you need a suture. Sometimes the nail already almost come out already, half broken, half there. You just give a ring block to the finger. Ring block, that means you inject around the finger to numb the area, then you can just plug the nail out, then you
Ooh.
just
Sorry.
Yeah, sometimes you feel gross, but actually it's not difficult to do. Just plug it out only, like you plug a tooth out. And then this is even more worse, right? You just inject it,
So how
inject
about
and
if
you
it's
stop the
the big toe?
just ring block. If the toe, the nail coming out, you just ring block the area, plug it out only, then dressing. Yeah, it's digital block, it's the same thing lah. Ring block, digital block. You block around like a ring towards the around the finger, around the toe.
I see.
It's just a words different lah. Digital block, ring block.
Okay.
Okay,
I
now
hope that
now
answers your question, Sophia. How about how you call it? Um, ingrown toenail, also the same way lah.
yes, the base of the digits. Sometimes if like fingernail, you want to inject around the midpoint also can, but usually people practice at the base of the digits. For ingrown toenail, I never seen any patients come for me for an ingrown toenail before, but I did treat my family members for ingrown toenail. Just cut a little, not even need an injection or some numb cream, no need anything. Just use a nail cutter, cut a little bit of fingernail out, the ingrown toenail will be recovered by itself.
Okay. So you were saying the procedure can be performed that could be performed with some training.
All right. Okay. For corn removal, how to numb the sole? Just numb the area. This one later you see. Wait. Eugene, later I'm going to talk about the white local excision and excision. Then you see.
Okay.
The bleeding difficult to control wise for the nail removal, you use some adrenaline packed gauze. You use a gauze, put some adrenaline on top of it, pack with it, then you just use pressure lah, just wrap around it. You stop by itself. Okay, now come to this see one, do one, and teach one technique. It's very common words for those houseman stroke MO training in surgical department. Always we say, we see one, we do one, we teach one. Like appendix, last time my junior MO time, the senior MO told me, appendix, you see one, then you do one, the next one you can teach people already. That's how we learn appendix. So
My
there are
God.
this procedure. I suppose we can see one, do one, teach one, and next become a regulator. There's a better part.
Oh my God, I hope our Malaysian medical healthcare is not like that, okay?
Now it's better. Last time used to be like that. That's what I faced. For
Okay.
lump excisions, okay, lump excision, I'll just tell you any skin or subcutaneous lump you can easily remove. Just numb the area, cut the lump open and throw it away, stitch it back. Like however way that you want to stitch. This one I had to share a bit of my lump excisions experience. I was a surgical house officer, not even a medical officer, in a daycare theater. Daycare theater means patient is under local anesthesia, fully awake. Then the MO supposed to perform the procedure. Then the MO told me, hey, can you do or not? I said, I haven't done before. I show you once. So the MO did, I assisted the MO did once. Easy, right? Yeah, easy. Okay, next one is yours. Then you look at the list, they got about 8 or 10 patients along the list. Then 2 MO disappeared. I learned the excision with the medical assistant, MA. Those days, MA are very good. They can do a lot of things. So they taught me how to do a lump excision local, and afterwards you perfect your technique by practice law. So my advice is not for deep structures and not for crucial structures like head, face, neck, axilla, and breast. This type of area, try to avoid it because the lump tend to have more problems. So these 2 pictures I put out, one is a sebaceous cyst, one is a lipoma. What is the slide there? The removal technique is the same. You not even need a diatomy, anything. You just use a simple blade to cut it out. Then use a stitch, suture, 2O or 3O interrupted nylon, ethylon, this type of non-monofilament, non-absorbable. quickly suture it, then put a, compression pack, put 2 gauze, put some pack on top of it, put some plaster on top of it, bleeding you stop by itself.
Sorry, just now you were going this sebaceous cyst and all. I see this pimple popper back to pop here. They don't
There's
actually do an excision. They do a small cut and then they kind of do like drainage. They pop it and then you know the cyst actually has the lining.
yes,
Will it
the
recur?
wall.
Not the
Yes,
wall?
it will recur. That's the thing I want to touch later.
Okay, okay.
It's okay. Since Dr. Betty bring up, I want to, then I talk here. This sebaceous cyst, there's a wall. If the sebaceous cyst, a lot of people just make a pop and squeeze all the chalky material out. When they squeeze all the chalky material out, patient will good temporarily. Then afterwards, the cysts tend to recurrent and tend to easily get infections and make your subsequent procedure more difficult. So the more advice thing is you have to take out with the wall. If you accidentally poke the thing, all the chalky material came out, then you have to extend the wound, scrape out the wall. You need to take out the cyst wall so that the sebaceous cyst wouldn't recurrent again. Before, these are the steps usually do. Give some local anesthesia. Usually I lidocaine, clean the area. Hopefully it's not a newspaper draping. Then incisions following some the Langer's line, our skin line. Then remove. Stop bleeding. You can use sometimes there's a bleeders but rarely you can encounter any bleeders. Bleeders you can put a stitch or 2 to stop the bleeding. Then you close the wound. Stitch the wound in interrupted suture, then quickly pack the wound. The bleeding usually stop by compressions. The consideration, there are 3 things I put up. The sterile technique, the equipment, and the assistant. You need to ensure that you have certain equipment, and you need an assistant to help you to hold all the retractor, and your technique must be in the sterile method. So those who never do this before, I wouldn't encourage you to try on patients. You better have some training, at least do one first. At least you see one first, only you can do one. Don't be like, I'm very good, I look at YouTube, then I can do already, a bit dangerous. You have to at least assisting and somebody supervise you to do one, then you know, okay, I can do this. Then next you can do it on your own to do all these things. As a point, I'll just touch a little bit more. This the same thing, the cross region, the area that you give anesthesia to numb the area. Then the line is the one to cut. Why in the sebaceous cyst, I will use an elliptical line, but in the lipoma, I use just a single cut. Because usually sebaceous cyst, the skin on top is not healthy. If you stitch the skin directly, the area, the wound tend to break down, and also the bleeding a bit more difficult to control. And usually the wound won't heal, and inside the cavity, you still have a cavity, there will some blood clot will accumulate in the area. So better is you remove the unhealthy skin a bit, so for it's easier to approximate. And when there's some tissue loss, the skin removed, you can thinking, if you can use simple interrupted suture, you use a simple interrupted suture. But if you cannot use a simple interrupted suture, then you use a vertical mattress suture to suture the wound will heal better. For a lipoma, it will be different. A lipoma, you can see a big lipoma, the wound is no need that big also can. If your technique is good, you need maybe half the size of the lipoma wound. The lipoma is like 6 centimeter, you just need a 3 centimeter wound, you can dig the lipoma out. As long as you know where is the plane of the lipoma. If you're not sure the plane, but better I tell you make a bigger incision so you can take all the lipoma out and you stitch it back. In the operation room setting, we have this diatemy, the one to stop bleeding. So if you have diatemy available, you can use a continuous subcuticular suture. The one the patient heal with single line, the wound is very nice. If you don't have diatemy and you cannot really stop the bleeding so well, then use interrupted suture, the bleeding will stop by itself. Okay, the next thing talk about is white local excision. Just now was just excision only. What is the difference between white local excision and excision? I'm going to tell you in the next slides. This will tell you when you're suspecting a cancer or possible cancer, basically in the GP setting, you feel a mole, a nevus, or something we might be some melanoma, then you need to remove it with some normal tissue, with some tissue that which is a healthy tissue, so that you can ensure a complete removal. Then you do a wide local excisions. For wide local excisions, like this, to numb the area at the cross area, a bigger area, then the excision is an elliptical excision together with the mole or whatever structures that you want to remove. When you dig the thing out, I need to do an elliptical so that later I can close easier. The elliptical way is to following the longest line of our skin. Our skin is running vertical, you shouldn't cut horizontal. The skin will heal very ugly. If the skin is vertical, then you cut following the vertical, but in an elliptical way. After you cutting out the elliptical way, better to use the vertical mattress suture. Just now I mentioned the one, the more lecce type of suture, so that the wound can heal better because there's some tissue loss already. And usually you cut like this, you have some bleeding, it's common. So use the mattress suture, the bleeding is even easier to stop the bleeding. Afterwards, you send this thing, you must send for histopathological testing to make sure it's not cancer. But even if even there's cancer already removed with the normal structures, so patient should be all right. This is wide local excision. That's why you know it's different from excisions of the lump. The next thing is foreign body removal. Frankly speaking, usually the kids you come in for foreign body in the nose, in the mouth, they shove some pin in, some small balls in, some metal into the nose or into the ear. To remove it, you need certain technique, but the technique is not difficult to learn. You need a small equipment that can go inside and dig it out. Usually quite traumatized for the kids. You need the parents to hold the kids down, then you just go in, within seconds, you can dig the thing out already. So what is the distance from the lesion to cut out? Last time people did say, oh, need 1 cm margin, 2 cm margin. Serena asking this distance for lesion. Previously, people say 1 cm margin, 2 cm margin to be as a safe distance. But nowadays, the oncology take only what we call an ink margin. Ink is I-N-K, ink margin. As long as the pathologist can see a margin, the ink that just now you make, before you cut, you make an ink there, the pathology will make an ink. Or 1 to 2 millimeter is enough margin already. No need 1 centimeter, 2 centimeter. You just get around the thing as sufficient for you to close is enough already. So the words to answer this is an ink margin. Ink margin is just 1 to 2 millimeter is enough already. Okay, so back to this foreign body, you need to do at least see one, do one, then you know how to do. When you already do once, you get the gist. It's very easy. Only few seconds you can dig the thing out and patients can go back home directly. It's nothing too much to worry about, but you need to do once at least. I never do this during my locum time in clinic, but when I was in hospital ED locum, every few days there will be kids coming with this. Then initially you struggle, then your seniors say, come, I show you once. Then they do a small digging things to scoop it out. Then, oh, okay, done already. After you see people do one, then you do one. After you do one, okay, it's very easy. Then the next thing, parents come with the kid, hey, the metal ball inside. They don't worry, come. Then you get the thing, dig it out and settle. So this one you need
There
to
are really cockroaches in people's ears. Ew.
Yes. It's
Okay.
very easy to do. You just need an otoscope, put in, you see the thing, and you get the suction machine, suck it out only. It's not difficult to do. ENT earn a lot of money by doing a ear toilet actually.
Can we answer a few questions first? Just now, Eugene asked for corn removal. How do we
Sorry,
numb the sole of the foot? Have you answered that?
yeah, sorry, the one miss out only.
Yeah.
The corn removal, you can use a technique of this white local excision, but it's almost same thing. If the patient's usually corn is not that painful, you can dig it out without any painkiller. But if the patient really you can try to dig first. If the patients complain of pain, then you give some local injection of the lignocaine to around the cone before you dig law. And
Can you
corn, the good
cauterize
thing,
the corner?
yes, it's a cauterized technique. Usually there's thing I say, usually corn after you dig it out, you won't bleed. So if you don't bleed, then you don't need to suture. You just put the plaster, tell the patient to go back home. But the problem about the corn is tend to recurrent. When you recurrent, you just dig it out again. No? If you think you want to do a good job, sometimes you can do a proper white local excision, wipe everything out, and you start a little bit of bleeding. Then you use a mattress suture technique to stitch it back. Usually for corn, I've encountered quite a few times. Just dig it out and settle the story lah. Not even would have bleed.
Dr. Kaur asked that after nail removal, he found that bleeding is quite difficult to control. Is
Yeah,
there
this one
any
I just now
advice?
answered already. Use a ligno. It's a adrenaline gauze. Break an adrenaline vial, spray the adrenaline out, put in the gauze, the neat adrenaline, put in the gauze, then put the gauze pack on the toe and the nail bed there. Then you just wrap it with plaster. There's some pressure, the bleeding will stops. Then the last one, the Serena one, just now also say just the answer is the ink margin.
Okay.
Okay, hormone
Answer all.
pellet. Okay, hormone pellet. I myself never inserted before, but I heard people insertion is not difficult. Just numb the area with some lignocaine, some numb gel, anything, and there's that apparatus to inject the thing in, and you push the hormone pellet in, and go in easily. Just like that's just a injection with bigger needle only. This one I didn't inject myself. I just heard people, so I think it's quite a simple procedure to do in GPs.
Is it a regular thing that the GP does these days, right? Hormone pellet insertion? Anyone? And then when you do this hormone pellet insertion, does the vendor guide you through it?
This thing I cannot answer because I don't know. But the
Yeah.
next thing,
Implant
implanted
insertion,
insertion,
Serena
one of the
says.
hormone things lah.
So do they actually help you with the vendors help you with it? Anyone? Okay. So never mind. Film needs training. She said needs training. Learn in
Yeah.
KK.
It shouldn't be too difficult. Like I said, you do one, see one, do one, teach one. This type of things lah. It's not difficult, really not difficult. Okay, the last one is a more interesting thing. I will say interesting lah. This I have to admit, I never done before. During my times and in GP life, there is no Botox, no filler that time. This Botox and filler is popularized after that. But now a lot of GP actually giving this. And the feedback for them to me was, don't worry. If the vendor come to see you, you say yes, they'll send you for training. And they'll send you for training or send you for some short course, like 1 day course, half day course, then or even teach you where to inject. And sometimes you didn't get training at all. The vendor say, I send you some video clip or some animated video clip. You go and try it yourself. I give you free sample. You try on your relative. Whoever want to try, you try. So the GP took the free sample, went back home, inject all the relative that he has. Then he can train, the relative get happy. Oh, got this, got that, the effect is like this. So after some time you get, after some injection, you get confident, you do it. So this is maybe a little bit like urban legend or what, but really this happened. My GP's friend told me this. Hey, you know, to inject. Then even some people persuaded me lah. Hey, you can do it in your clinics. You know, you want to do or not? Ask the vendor to look for you. Then you give you free sample. You bring back to inject and your relative. So yeah,
Oh,
I know.
so Shawn, you can try on me now when we go to work. You can try on me. You
There's
don't need your
Serena says
relative.
Tosis.
I need
Tosis,
it.
you have to. There's Tosis is by Botox, not filler. Filler wouldn't cause Tosis, right?
Oh, I see. Filler and
Uh,
Botox are two different
Two
things.
different things. Botox, you relax all the muscles, so you get toxics. Filler is fill up all the wrinkled space, so you feel like more
Oh, I
things
don't
there
think I
to
dare to do
reduce your
fillers now.
wrinkle.
I think I dare to.
So you can try lah. I haven't tried myself.
Yeah, I
Yeah,
think
it's
Serena
techniques
is
lah.
correct. I think one way for me to actually tell that something has been done to somebody is because there's an imbalance. There is actually asymmetry. I'm very observant about something that's asymmetrical. So most times the hand is very heavy on one side and an injection for the other side is less. So it's not always sorry, Dr. Wong
Hmm.
asked, what about CGM in like freestyle Libra? I don't know what is that, sorry.
Yes, I also don't know what is that actually.
So what is that? Huh? Okay, let me just Google that. CGM, uh, like
Okay,
freestyle.
for the time being, we just proceed a bit first.
Yeah, go on. You
After
go on
this,
first.
because after these slides is this more specialized procedure. I'll say sometimes some more specialized procedure, you need more training. So when you say, oh, you can do this in clinic, continuous glucose monitoring, I haven't,
Yeah, I've got no.
I don't have any experience about that.
I also don't
So
have any.
I cannot tell you about that. I know some diabetic patient, they have an insulin pump attached to them. The insulin, you are going that 1 milli unit per minute or per hour, something like that. But I'm not sure about the continuous glucose monitoring things lah. Never encountered before. As you know, my
Maybe
locum time
this
was
continuous monitoring is done by, I'm not sure. I've never seen it before myself, anyone using it.
my locum time was too far ago lah. Yeah, my locum time was too far away. The last locum I did was 2012. After 2012, there's no more locum for me. So the new thing I really not encountered lah.
Yeah. So it's for
Then you
glucose
think
monitoring.
that's why the first slide I tell you is by there's a ruler in your heart. You think you can do it, then it's safe, then you do it. Yeah, the
Okay.
CPG didn't mention about this thing, I think. Okay, we come back here. The
We
more
come back there.
specialized procedure, I would say there are procedures that GP do on and off, I heard, but this type of procedure, you need to take it with a pinch of salt. Don't just add a lemon and a shot of tequila. Think properly first. So skin laser, more and more people will do already. Despite skin laser, there are some skin peeling. They use a chemical peeling, some chemical things, product, apply just sapu on the face. Then when it's dry up, just peel it off. Some GP did that. Laser time a little bit far from me, but I heard people doing, especially for some pigmentation removal, mole removal type of things. They say laser is good. They wouldn't bring harm to the patients. Is a controlled method, is a non-invasive method. But one thing is laser is very expensive lah. But the lasers vendor will provide you training for sure. This one because one laser is count by maybe 6 digits to get one laser machine. Yeah, this Serena looks like very look good about this cosmetic aesthetic thing. I am not touching that. I just know people did that. And some of my one of my GP friend, she did chemical peeling for patients. So I know here and there a bit. I call her and say, hey, this thing you do or not? And she give me some advice about this. Oh, this thing can do. Oh, this thing can do. I say, okay, okay. By the way, she is not an aesthetic doctor, just a GP only. Okay, next thing is hemorrhoid. Hemorrhoid, I try to show a picture of hemorrhoid, or we commonly call pulse lah. We don't bend external pulse, we only bend internal pulse or internal hemorrhoid. In the proctoscope, you see the hemorrhoid, something like that. But in a colonoscope, at the end of colonoscope, you can see at the colonoscopic view, the hemorrhoid will be like that. We bend second degree hemorrhoid only, not first degree, not third degree. Third degree to do surgery, first degree just by medication, Deflon only. So if you want to bend, only bend second degree hemorrhoid. Actually, hemorrhoid also a bit struggle. Want to put here or to want to put there? Because after you see 1 or 2 times, you bend 1 or 2 times, you know how to bend already. In fact, there are a lot of doctors outside help people bending hemorrhoid. Even some Chinese sincere help people to bend hemorrhoid. Because I have patients come to my clinic, tell me, oh, this clinic, what okay, it's called a hemorrhoid doctors. You go in, you bend the hemorrhoid, you recover from hemorrhoid. So there are a lot of doctors outside help people to bend hemorrhoid. What you need for hemorrhoid bending is very simple. A suction and connecting to a sucker tubing and also a hemorrhoid set. This hemorrhoid set is a disposable set. So you use and you throw. Hopefully there's nobody reuse and reuse and reuse again. The gun shaped thing is to suck the hemorrhoid into the gun. And the other thing is a proctoscope to see the hemorrhoid, like a proctoscopy just now I show you. How it's going to do is you connect the tubing into the gun, the suction gun. Then you see this picture. This is a suction gun. The head there is pointing toward the internal hemorrhoid. Then you apply it to the suction machine. The other side of the suction gun is connecting to the suction machine. So when you near the hemorrhoid, you suck the hemorrhoid inside that. After you suck everything in, you just apply the rubber band. Just there's a trigger there. You trigger the rubber band, you bend on the hemorrhoid stalk. Then hemorrhoid considered done already. After a week time, the hemorrhoid will fall down and the patient recovered. This
You need
rubber
sedation
banding,
for this?
no need anything. Internal hemorrhoid shouldn't feel pain. Internal, the trick is you have to bend above the dentate line. If you're not sure the dentate line is a line between the anus, between the squamous cells epithelium and the columnar cell epithelium in the anus. You see the picture, you can see there's a line. Internal hemorrhoid is always from above the dentate line. You can see the picture, there was a line, some distinct line over the anus region. The internal hemorrhoid always above the dentate line. So you go above, you suck the hemorrhoid in until above the dentate line, then you bend it. So it's a bit difficult to show a picture and teach you how to bend. That's why this procedure needs a little bit specialized training. You need to see at least 1 to twice, then you know where is the hemorrhoid, then you know how to suck and how to bend. After you see 1 time, a lot of people see 1 time, they know how to do already. So it's not a difficult procedure. That's why a lot of doctors outside, they do this rubber bending. The equipment you need is a bending set and a suction machine. And I believe a lot of clinics have this suction machine for all this flame suction, all this can use this sort of suction machine, no problem.
See. Is it very expensive, this machine?
Shouldn't be lah. It shouldn't be too expensive machine. More and more coming. The laser machine is more important, more expensive. The next I'm talking, the ultrasound machine is more expensive. This ultrasound machine we share in the hospital lah. I think Dr. Betty has used this machine before. I myself using this machine before, the ultrasound machine. So I use this machine to scan all the thyroid, thyroid lump, neck lump, any lump around the body. You can see, you can scan, you can put the Doppler signal to show, and you can measure. And with ultrasound guided, we can use a biopsy, some apparatus attached to a syringe to do any FNAC or biopsy lah. You can use ultrasound to aim on the lesion, then you put the needle in and suck some sample out. Then the sample can be used, can send for pathological testing to see whether it's benign or malignant. It's ultrasound guided FNAC. But this thing, there's a prerequisiting factor that you need. You must master your ultrasound technique. You do until you master the technique. How I learn my ultrasound is I do every patient come to my clinic, I do ultrasound free. But okay, I do ultrasound for free. I do ultrasound for free. Do until a point, you know, or you automatically pick up the technique. So for FNAC, you no need FNAC stand for fine needle aspiration cytology. You no need any anesthesia. You just need some anesthetic spray lah. Others, why these anesthetics say the xylocaine spray, which I always use the picture here. Others, why in biopsy the needle is bigger, usually an 18 gauge needle. FNAC usually a 21 gauge needle. Biopsy sometimes I use 16, 14 gauge needle. When you 16, 14 gauge needle, inject some local anesthesia agent on the area to prevent the pain. It will be better for the patient, or else patient will cursing use such big needle going in. And you know, ultrasound, you need a medium to see. If you don't have a medium, the ultrasound won't reflect the image out. To get as a medium, I use this. This is in my clinic also. This thing, actually a lot of hand sanitizer now. This sanitizer gel very good. You just put on the skin area you want to ultrasound, then you can do procedure because consider quite it's alcohol based and it can kill quite a lot of germs. It's quite safe for ultrasound. But if you want to do any ultrasound guided biopsy or FNAC, I would advise to do some breast nodule, thyroid nodule, superficial neck lymph node, and superficial neck lump. Don't go for abdominal, thorax, and all these crucial structures. It's very dangerous. You accidentally punctured other things, you get things worse. This one also, you see people do few times, you master up your ultrasound technique, you should be able to do. The thing is, you need an ultrasound machine in the clinic. So the next thing is become more interesting, circumcisions. Nowadays, everybody thinks circumcision only can be done in operation room. In fact, out there, a lot of people do circumcision everywhere. I believe some Malay, they this campaign berkatan sama-sama in some mosques also. And some doctors will go to the mosque and do this campaign berkatan. So this is the thing that picture taken one of the campaign berkatan. The doctors there do circumcision, then the patient there taking photo. Oh, this is my thing. Doctor, how to cut, how to suture. This one you need a little bit more practice and learning. I cannot teach you online and tell you what to do and how to do it. You need to see, do, people supervise you do. After you master it, you can do it quite easily. Do under local anesthesia, like just now, blocking is a ring block around the base of penis, and patient won't feel pain. Then you can do it already. The only thing is the bleeding. You have to master the bleeding. I'm going to talk about the bleeding in a while. So I want to show you this thing first. Tara clamp. Tara clamp, I will call it an urban legend also. I personally never used a Tara clamp before, but I know somebody using because on and off, their patients came to hospital with a area of necrosis around the shaft of penis or just at the base of the glands because of this Tara clamp. Apparently, the doctors put the
Oh, Shawn, lost Shawn again. Anyone use this one before? Tara clamp?
we will call
Anyone?
it the urban legend. You see, you're quite worried about that, but in fact, they are outside. There are really people doing that. But you ask me what you want to do. You want to do a circumcision, train an open method and learn an open methods. Oh, yeah.
Yeah, yeah, you're laggy. Okay, let me see. How many more slides do you have? Okay, he's gone. I think, let me see if I can share my slides. Okay. So this is our CPD points. Let me just put it up first before just, can you all get the code? Check. Okay, let me just see if I can do the, sorry, because this is my first time myself. Oh, got it. Okay. So I'll put it there first. Okay. Shawn is back. Yeah, I just close this first. Okay, Shawn, you're back.
Right.
Where are you?
I'm back.
Yeah, Shawn. I just shared the
I-
code and I was able to. So yeah,
Yeah, I saw the code.
okay.
All
So
right.
let's finish off
Okay,
this.
now we come back to circumcisions. Okay, this usual method of circumcisions: pull the foreskin out, cut around it, and stitch it back. There's an area called frenulum of the penis. Usually, bleed is from the frenulum bleed. So your suture need to double suture the frenulum to stop the bleeding. As long as you master the frenulum, then it's all right. The bleeding usually can be controlled easily. Where is the frenulum? Is at the dorsal part of the penis where there's a line or there's a cord pulling out the penis. There's the frenulum. You can see this picture. This picture didn't show a frenulum. Opposite this picture, there was the frenulum. You need to at least see some people doing a frenulum, doing a circumcision first for you, and assisting in some circumcision before you can master the circumcision technique lah. So you shouldn't be like gun ho see some video clip and do it. Actually, before these things, I online Google, there are a lot of video clips show people how to do a circumcision. Surprisingly, I don't suggest you to look at the video clip. Yeah, my internet got problem again. Why? All right, okay. Um, yeah, you need to see and do first before you daring engage in circumcisions. But when you do it already, it's not a problem. You don't need any diatomy. Don't use any diatomy in circumcisions. If you want to use diatomy, use a bipolar diatomy, not a monopolar diatomy. So a lot of people do. That's why they can do a campaign berkatan of the circumcisions without double
Serena asked, what
sutures.
do you
You
mean
need
by
to
double
suture two
suture?
times. No, just now I mentioned double suture of frenulums. You need to
Yeah.
suture two times the frenulums. There's a cord-like structure. Suture the right side very near to the cord and left side near to the cord in the figure of 8 method. Is like you suture two times like a continuous two round, then you tie it up. So it's called it double suture. All
Okay.
right.
Okay, we need to wrap up soon because we are almost
Okay, this is the
finishing.
last already. Sorry, a bit
Okay.
extended. Their GP did do termination of pregnancy, but it's against the law. Then I don't encourage you all to do. But my GP's friend did tell me they do termination of pregnancy, don't know by weeks. First week of first week of pregnant is 1,000 ringgit. Second week of pregnant is 2,000 ringgit. Third week of pregnant is 3,000 ringgit on top of it. So whatever is against the law but I know people doing this. Okay. As summary, the common routine procedure are here: incision of drainage, abscess aspiration, branula, bladder drainage, wound dressing, wound debridement, and simple suturing. For need some training, lump excision, white local excision, foreign body removal, hormone pellet, and also this injection of Botox, whatever things that you think of. For more specialized training like hemorrhoid bending, ultrasound FNAC, circumcision, skin laser, and finally the termination of pregnancy, which is not encouraged. All right, the last is about workshop. If we organize suturing workshop, then we can show you some different technique of suturing. If anybody
Oh, that's
interested,
great.
next time we can organize once.
Yes, we
Not
will
online,
try
it's
to organize
a real
one.
life workshop. I have a lot of years, at least organized 10 or 20 workshops before this for suturing techniques.
Okay.
Any
So please
questions?
leave your Q&A while we share this one. So please, I can't see the questions now when I put up the slides. So how?
For, sorry,
see
Serena asking,
the messages? Can you see any of the questions?
no, I see
Any?
Serena's question. Biopsy, is there any specialized instrument? Yes, there's a biopsy by what I call a gun biopsy. There's a once used things. You can just Google any biopsy gun, then you'll find out it's a once used that repeated use and there's one use. Usually I use the one use things. They are come in the size of 16, 18, 21. So choose the one.
Okay.
Periannual hematoma. What you need to know why the periannual hematoma before you talk about how to approach it. A lot of time, periannual hematoma is a thrombosed hemorrhoid. When you face a thrombosed hemorrhoid, I'll suggest you, if you have no experience, send to the hospital. If you have experience, then good. Just make a nick for the blood clot to come out, then pressure for a while. You don't try to suture it back. Just comfort the patient. This blood clot is going to stop. Then ask them to use this sitz bath, soak in salt water, and eventually you stop and you heal. So this is how to deal with the thrombosed hemorrhoid. About plantar mosaic warts, warts, you want to remove, you remove lah. It's very easy. You just cut it out. You're bleeding, you put a stitch to stop the bleeding. But the problem about warts is you come back, it keep recurrent. So you have to tell the patients, this thing I can cut it out, but it's keep recurrent. So if recurrent, you can just come back, you keep out. You want me to take out again? I take out again, no? You have to tell them the recurrent, or else patient say this doctor is lousy. Take out my thing and it's come back
Oh,
again.
no, Amalina says she cannot open the code for CPD. Okay, no, Amalina, you have to go to your, if you're using you need to use a laptop so that your phone can scan the code. You cannot click on the code. So basically, you go to your laptop, and then you're watching from the laptop. You go to your phone, okay, click on the MMA event app, and from there you can see scan code, then you scan it. Cannot open from clicking on the screen. Okay. Serena asks, is there any risk of IND for base of
Yes, this
scrotum?
is a scrotal abscess. Just now I didn't mention, but what I want to tell you is scrotal abscess don't treat, send to hospital. Because scrotal abscess, first thing is it might be a Fournier's gangrene. Secondly is even though you do an IND, it's also very high risk to become a Fournier's gangrene. When become a Fournier's gangrene, it's a very big thing, and patient is going to complain that this doctor make a nick and make the thing worse. So not worth thing, or just to drain the abscess and make the thing and make the patients complain you or sue you later. My advice is scrotal abscess don't treat, send to hospital. Then cryotherapy for the indication for refer and abscess. If the abscess you think you can drain, you drain it. No need to refer. If you think you cannot drain it or too deep thing, and you refer to
No,
to
if
the
it's a
hospital.
scrotum
It's up
abscess,
to
you
your
just
how.
mentioned that. Yeah.
Yes, scrotal abscess refer. Don't treat. Other than scrotal abscess, or most of the abscess you can treat lah.
Okay, just now I
Then
could.
cryotherapy for the warts. I read this before. It works. Sorry.
Hold on, I could see the chat. Okay, saw the chat. So cryotherapy for warts. Cryotherapy
Yes.
for
All
warts
right.
possible,
Okay.
right?
Can,
Keloid. Oh, keloid is very difficult to treat. No? What do you think, Shawn? Keloid. Keloid. Shawn? Okay. Shawn is not with us at the moment. And I'm trying to get, okay, I've, so keloid, I think it is very difficult to treat. Some people give a injection of steroids, and I don't know whether you would like to attempt that. Bartholin abscess, friendship, perianal abscess, and deep set. Okay, we need Shawn for this. I'm sorry, I can't help you. I have not. Shawn is coming in again. Shawn? Okay, Shawn?
Sorry, was again.
Okay, so there are a few questions. Dr. asked about keloids. How would you approach keloid? Maybe this will be a better, the skin doctor will be a better person to ask, yeah?
I have experienced keloid is using this kinocort or syncort injections. One syncort 40 is a 1 ampoule is 40 milligram injection into the keloid together with lignocaine injections. One dilute to 1 or 2 also never mind. Inject into it. After a month, the keloid becomes smaller. You want to repeat, is after a month only repeat. Can repeat up to 6 and 7 times lah. But usually I injected 2 to 3 times, the patient feel very happy already, then no need to come back again. I have this experience before injection of keloid. Is it Serena say intralesional? I only see this message only. The previous message all lost already.
Okay, so they ask, somebody asked how to differentiate perianal abscess and perianal fistula in a GP setting.
You need to see once lah. Fistula and abscess is present differently, but at a lot of time, an abscess you have a fistula inside which you will miss. But if you see a perianal abscess, it could be a fistula hidden or it couldn't be a fistula hidden. Never mind, first drain the abscess first. The fistula happen, we deal later. Unless it really starting presenting as a fistula, then you cannot treat it to send to hospital already. Fistula is a headache of not only GP, but a lot of surgeon facing headache, including myself. Because fistula, you have to tell patient is not single operation can settle the problem. The fistula tend to be long-term, need long-term follow-up, long-term handling with the fistula, and might need more than one operation to settle the fistula. So a lot of surgeons dislike to treat fistula because of this long-term thing. You cannot handle properly, cannot build a good rapport with the patient. Patient is going out to tell this surgeon lousy, this doctor lousy, cannot deal my fistula, cannot deal my S problem. But in fact, perianal fistula is very difficult to treat. So when you face a perianal fistula, you send to hospital. When you face a perianal abscess, you think you can drain, you give some local injection, you drain it. But have to mind you that perianal region is very sensitive. A lot of nerve ending, the pain might be quite intense. You can tell the patient about this, whether they want to drain in your clinic, then you think you have just make a cross incision and drain the pus, or you think you cannot handle the pain, the patient might feel too much of pain, then you have to send to hospital.
Christine asked, what about Bartholin's abscess?
Bartholin,
is more gynae lah. More gynae, sorry.
Gynae already. The procedure is called marsupializations. You need to open up the abscess and stitch up the thing, make it open up. I did before, but it's not in GP setting, it's in hospital setting.
Okay. So Serena said, what if the scrotal abscess is very small and visual? Like Shawn said before, it is what you have in you, do it or not to do it, you have to take the decision. Okay. I think he started off with that, right?
Yes, all the corneas gangrene starting with that. If you think it's very superficial, very small, you just make a nick, you come out, then you make a nick and make it come out. Then, but you have to tell the patients that in case you give cover antibiotic, of course, when you tell the patient, in case it get worse, quickly come back to see you or quickly go to hospital. Choose either one. Don't let it like wait for see another 2 3 days only come back. Anytime get worse, anytime go. Then you have to able to identify early sign of corneous gangrene. You miss early sign of corneous gangrene, then you flare out. It's very difficult.
Okay. So I'm going to end here. We have done 1.5 hours. This is one of our longer session. Very interesting indeed. A lot of it, I regret to say I've never done as a doctor. So let me see. There are
I
some
have
more
too many things
questions.
to talk, so taking too long.
Okay.
How to fully express out pus in a perianal abscess? Okay, the thing is irrigation. Use a syringe filled with saline, and you can
Oh,
connect to a big ball radiola without the needle inside, just a soft one. Shove in as deep as possible, then keep flushing. Then the abscess will come out.
okay. Dr. Ng asked how
If
many has seen.
you think that immune
Sorry, go on. Sorry.
with the perineal abscess, I got one more point to say. If you know what is sitz bulb or not, after you drain the perineal abscess, ask the patient to do sitz bulb at least 2 times a day. You help the abscess drainage. Sitz bulb, you put a basin, warm water, and a handful of salt inside, dilute it, and ask the patient in the squatting position, dip the S into the warm salt water. Then you make the abscess, the pus come out. So you don't need purposely go and drain all the pus. By times the pus will come out, the abscess will heal. Perianal abscess is very easy to heal because of, I think one of the things is because of the blood supply there, very, very good blood supply.
Okay.
All right,
Dr. Ng
last
asked
thing
whether
is
how many have seen a Fournier's gangrene. I have. Okay. I had a patient who was seeing me for just high blood pressure, and then he came in one day with a low blood pressure. It started off lunchtime. He went to a wellness clinic, injected some saline with. Whether he went for chelation, what or injection of vitamins, I am not sure. Well, they suggested it to him. So lunchtime he went and did that. By 4 o'clock he was septic shock, and then he had the Fournier's gangrene the very next day. So he had severe sepsis. He was in ICU 6 weeks. But he recovered well. He recovered really well with complete recovery. So he was very lucky. But it's very important, this sterility, yeah. Very, very important. So anything else? Not but end here. I hope you all manage to scan that for your CPD points, and then we will see you next week. Next week there's no CPD points, but next week we will have a hematologist with us, and we will speak about blood products. And this is more important for house officers and also the medical hospitals. Okay, speak about, and we will break for prior. And tomorrow is a public holiday. So, and thank you for this webinar again. Much appreciated. You're welcome also. So thank you, Shawn, very much. It's a very interesting talk. As you can see how interesting until we are here until 10:30.
yeah.
I'm so and I hope you enjoyed yourself
Yeah, I hope
giving us all
everybody
this
get at
talk.
least get something back home and get
Yeah,
some
yeah, I think it's very
information.
I love these webinars actually. One is because I myself learn a lot, because I regret to say that I've not done many postings except for housemanship, and my housemanship was only 1 year. I did 3 posting, orthopedic medicine, 4 posting, orthopedic surgery, peds and medicine. And after that I went straight into medicine and straight into cardiology. So I really never
Yeah,
actually,
different
so I'm
people have
learning a lot.
different experience lah.
Yes, that's right.
Yeah.
I'm learning as you are teaching. So, okay, I'll see you at work then of one of these
Right.
days.
Okay. Right.
Bye.
Right.
Thanks,
Okay.
guys.
Bye. See you all. Bye.
Okay,
All right.
see you.
Okay.